So what I'm going to try and do is use the experience not only as a GP trainer, but also I'm an appraiser and I teach medical students at Buckingham University and on the new trainers course. So what I've done is actually tried to put all these bits together to try and actually get important view, not only giving feedback, which you do as an educator, but actually the importance of receiving it as well. So I don't know if any of you've had any training receiving it, but that's something a bit different for today. I'm also a mentor for Rich and Goru on the Northampton training scheme, so I'll probably pick on them a lot. I'm also aware you've had a really, really long day, so I'm really going to try and make it as practical, as interactive as possible on the Zoom. So first slide, please. I'm going to have to do a Chris Whitty. First slide, please.
Oh, is that working?
No. We can see it. Can you do a slideshow so it's bigger or not?
Let me see.
Yes, okay. Number 2. Slide number 2.
If you do slideshow, yeah, perfect. Okay, so we're going to have a brief introduction to what we mean by feedback. We are going to try and put you in probably 2 or 3 or 4 groups to actually share your experiences, just to break it up a little bit. I'm going to talk a lot about receiving feedback about as a GP, but also link into the appraisal feedback you get, so we actually know what you need to do for the next few years. I'm going to look at the principles of good feedback. We are going to do a bit of theory, you'll be delighted to know, with the models of the feedback. And then if we get time, we're going to practice a little bit as well. Next slide, please. Lovely. Robbie Burns, I don't know how many of you know him. Feedback's been around for a long time. He was born in the late 1700s and he was a very famous Scottish poet. And this is a quote for him, and actually what a power of the gift we could be if we actually see ourselves as others see us. So it's actually, even that is not a new concept at all. Next slide, please. But also it's obviously used in all walks of life. We're not just talking about medicine or education or anything else. We've got Greg Wallace, who doesn't always give feedback very well, shall we say, to the contestants on his MasterChef. Next slide, please. And in this world of feedback, we're always seems to be everywhere we go, we're being asked for feedback. And whether it's numbers 1 to 10 out of a chart, or if it's, you know, give us ranking everywhere you go, even if in the supermarket says, how was your service today? So we're actually trying to do, but what I'm going to try and do is actually explain how you give it well and receive it well. So next slide, please. And what I'd like you to do is let's try and use the chat, and just if you can actually jot down what sort of feedback you're used to. Who do you give it to? When to do it? Let's talk about medicine, and you know why, when. So let's just have a few thoughts from you all to wake you all up, and a few things of what is feedback. What do you understand by it? I told you I'm not going to do all the work tonight. Lovely, right. Informal versus formal. Okay, Rich, I'm going to pick on you. Give me an example of some formal feedback. I've always given you one, patient satisfaction. Any other formal?
Yeah, so I mean, I recently registrar, so we're getting a lot of feedback from whether supervisors or trainers, as they were. So that's evidence of formal, and obviously ARCP panels are a good form of formal feedback.
Good. Yeah, and the other words that we're just going to introduce you to is formative and summative. Can anyone give me an example, tell me what the difference between formal and summative feedback is?
So formative might be kind of areas to improve as you're going on, doesn't really matter for progression. Summative can be some things like exams or something that you have to achieve for progress.
Good, lovely. And I think that's really, really important, because most of the feedback we receive in general practice is formative now. You've hopefully unless you don't go on and do different degrees or whatever, you've actually probably received most of your summative feedback. Occasionally in general practice, is not very often you have summative now. So it's all going to be mainly informal and formative. That's what I'm hoping. And I think it's really important, Harry's written here about colleagues within the practice. I think actually this is much more informal. You often get something, you know, from one of your colleagues just giving you feedback, a patient they were seeing, or something you've done really nicely for somebody. And I think we probably don't do feedback enough to each other. So we're going to look at form of that. And one of the appraisal requirements is that you actually do reflect on feedback, not only the formal stuff, but you're encouraged to put informal stuff as well. So I think it's important from colleagues, but also from patients. Which is written here that actually body language, if you have a patient who's really closed, is not speaking, doesn't really want to say very much, you know, that's giving you feedback that things aren't necessarily going very well. Okay, next slide, please.
Apologies, there's a bit of a delay on the slideshow, but give it a moment.
So what I'm going to try and convince you is that feedback is a gift. You're actually donating to somebody. You're actually something that we all want to give and we all want to receive. So like a proper gift, if you're giving it to your best friend, you go to the shop, you choose it really carefully, you wrap it with a beautiful pink bow, and you give it at the right time and give it openly. And this is a quote from Psalm 103, which is "Praise my soul, the King of heaven," which for some reason we used to sing at the beginning and end of every school year I had. And that's sort of like slow to chide. So actually, let's stop ourselves giving so much negative feedback and let's say a bit more positives to colleagues, especially. Next slide, please, and then skip a slide because we've already done. And the next one, yep. So we've talked about, we're going to come into the colleague and patient satisfaction survey in a bit more. Compliments. We rarely these days sadly get written compliments for our patients. Probably 10 years ago, it wouldn't be unusual to receive a Christmas card or a letter or anything from patients thanking you. Nowadays, it's less common, sadly. Occasionally you get it on the website or anything else, but there's still quite a lot of verbal compliments about. And for your appraisals, you are encouraged to actually write these down. So if a receptionist said, "Oh, Mrs. Jones has just walked out and said, what a lovely doctor you are," just jot it down somewhere, and just to be able to discuss it for your appraiser. Gifts, again, you do get gifts in surgery at times, maybe just something as simple as a bunch of flowers or a box of chocolates. You have to be careful with this because you have to look at why the patient is giving you the gift. And most of your practices should have gift policies. And I know in our practice we used to have that you had to put in a gift policy book anything that was over £50. So that's sort of like a probity issue. You need to have a look at that. Sadly, we will get complaints, and that is obviously a feedback that may not be a positive feedback this time. And so again, in your appraisals, you need to actually reflect on those complaints and actually describe the learning objectives and what you can do differently outcome. I put this one at the bottom, referral outcomes, because it's not actually a proper feedback, but it's something that I do and I encourage you all to do. Just very, very simply, in this day when general practice is so fragmented, we often don't know what happened to the referrals that we sent in. The letters come back to admin, or they come back to another partner or somebody else in the surgery. So I would encourage you to write down a list of your referrals. I wouldn't do them all. I don't think that's necessary, but you may want to look at all your emergency referrals, or if you're a bit unsure about orthopedics, write down a list of all your orthopedics. And then just in 2 or 3 months' time, or however long it takes for the patients to get seen, is to actually look back. And it's a real positive reinforcement that you're actually looking, you know, that breast lump really was breast cancer. But also the opposite. If you sent somebody into the rheumatology and you thought it was inflammatory arthritis and it was just osteoarthritis, just actually have a think and reflect on it. So that's just something you can actually look for feedback more specifically. So your appraisal requirements, next slide, please. And basically, it's a patient survey, which is every 5 years. So even though you have appraisal every year. You only have to do the patient and the colleague survey every 5 years. We encourage you as appraisals to do it in the first, or in about the second or third year, with the argument being that if it is things that you need to improve, that you've actually could then repeat it again before your revalidation. I have never yet seen somebody do more than one in a 5-year cycle for obvious reasons, but that's the discussion about doing it in years 2 or 3. And as I said earlier, you do have to reflect on your complaints and compliments, which you can do on your appraisal toolkits. So let's have a look at what's known as a Johari window. Let's go to the next slide, please. So this is, I'll try and explain it to you in a bit more detail. These are obviously, if you go along the top, these are things that you know to yourself and not known to yourself. And obviously down the bottom is known to others. And what you're trying to do is maximize the arena. You're trying to maximize that open arena. This is the area when you get to like free activity. Everything is known about you by yourself, and everything is known by a group of people you're working with. And this might be behavior, attitudes, feelings, knowledge, skills, and that's the whole idea. And you're aiming to have this as large as possible, because this is the most effective area for team working. And obviously in a team, the newer team members tend to have a smaller. So it starts off all equal. But if you expand it horizontally to not known to yourself, this is where feedback comes in. Because this is, the blind spot is an area you want to try and make smaller, because this is an area that you're not really quite sure what your skills and issues are. But actually, if you get feedback from others, because they know it by definition, because it's in that box. So that's what you're trying to do for improving. That's what feedback is trying to do, is to help you know things that others don't. When you've got not known to yourself and not known to others, this is obviously your facade. This is your hidden area. And this might be about information you've got. This might be feelings. And to actually try and make this box as small as possible, it's actually trying to be how open you are with your colleagues about how it's going to be. And the idea is to make your unknown unknowns in the bottom right hand corner as small as possible. But actually, it may just be for factors that, you might not have had the opportunity to do something. You might not have the confidence. So that's really just all the ways. And the idea of feedback is to help you improve and actually get more things that you know about yourself and to actually share with others. Next slide, please. So I've discussed a little bit about the point of feedback. And this is a quote from an educationalist, Mahane, who we use a lot on the new trainers course, the essential handbook for GP training. And it's been proven it's the most powerful single modification that enhances your achievement. So that's what we're trying to do, is make you achieve more. And another quote is the lifelong of blood. Right, so feedback is not, oh, next slide, please, sorry. So if we're going to have feedback from, sorry, Ruth, we're going to go into small groups in a minute.
Okay, lovely. Thanks for the warning, Fiona.
Sorry, that was a bit of a late warning. So receiving feedback is not always easy. So what I want you to do in groups of 3 or 4, who's going to sort you out, is have a think about what happened. How did you actually feel? And I don't want it to be about when the feedback was done well or not well, not about what you actually did yourself. I want to look at the process of feedback. So I want you all to think about an incident that happened to you, how you felt, and did it help or hinder learning? And then I want each, I'm going to give you only 10 minutes each for it, and then we'll bring everything together. And I want you to actually look, what was good about the feedback? What makes good feedback done well? What was less good? And maybe start to look at maybe some of the barriers to feedback. Okay, so example, time is a barrier to feedback. We're all completely busy in everyday life. We don't actually think about giving people feedback. So that's just an example of some barriers. So I want you to come up with a list of share a few stories with each other. You don't necessarily have to share it the whole group at the end. That's up to you. But I want you to start thinking about some positives, when's feedback effective, and what are the barriers to it? So if Ruth's ready,
Yep, I'll open the rooms now.
if you open the rooms, and then we'll just give you 10 minutes, nominate a spokesman. If you want to share your story, then please do. People have often got some very, very horrendous stories, but we'd like to hear some good ones as well.
Is it the three of us?
Hello? Yeah, I think it is actually.
Okay.
Let's turn my camera on. Hi.
Hi.
What's anyone else here? Hello. Hi, I'm Preet. Nice to meet you.
Nice to meet you. Toasting.
Hi, Julie. Hi, Tosin.
Hi.
Hi, Philip.
Philip, is it? I think we've met, isn't it?
Hello?
Outside of the gym, you'll probably find me doing this a lot and then holding myself like this. Sometimes, like the body language.
Hello?
Right, so as I say, obviously we all did this, but I'm just going to pick on a couple of people just to give me some thoughts from their group. Let's, Katie.
Hello?
Katie, could you put your camera on so we can see you? Hi,
Hello.
good evening. I'm being really mean and picking on people, but it's really difficult when I don't know you all. So can you just say some of the themes that came out of your group?
Yeah, so we basically, in summary, and a number of us shared some feedback that we'd had, and that what we felt was, what was brought up was that for feedback to be useful, it needs to be time relevant. So there's no point in giving feedback 6 months down the line on something that happened a long time ago, which you can't really remember the details of. I think as well that also the expectations of feedback. So I mentioned about an appraisal and what was expected during the appraisal, but the feedback given wasn't quite in line with the expectations. So that was something else to consider. And then someone else mentioned about positive feedback, which is really valuable, especially if it combines two aspects of this, combine both the clinical and also the professional nature of that individual involved as well. So they were the main things, I think, unless I've missed anything, Becca, that you can remember.
Yeah, no, I think that sums it up nicely, really. Just I think it was someone was talking about a negative experience of feedback and how the feedback had been given about 5 months later, and then obviously that makes you feel very negative, and also it doesn't give you an opportunity to either clarify any misunderstandings or rectify any behavior. And I think all of us identified as well, it's much easier to recall negative feedback about yourself or about your performance than it is the positive. And sometimes it can be quite, not upsetting, perhaps is too strong a word, but it can be quite difficult, particularly if it's a long way down the line, because you think, well, I've been going on like this for 5 or 6 months and no one said anything. So I think those were the themes that all 4 of us really felt were, common to us 4, and I presume lots of other GPs as well.
Yeah, thank you very much, especially that bit that we all remember, the criticisms, and that's why I suggest you actually collect your compliments. So when you're having a really, really bad day, actually just looking at that Word document of nice things people have said about you, it does help to balance it, because we all do, or as human natures as doctors, we all think of the negatives. Jesus, have I said that right? Are you in the same group as Katie or a different group? And you need to put your microphone on.
Okay, no, I'm different group. Okay.
Different group, okay. Let's hear from your group then.
I'm Jesus. I was with Efe. Yes, we were talking about the differences, for example, the timing when the feedback is received. Okay, it can be produce a huge difference between, for example, feel that the feedback is not a feedback, it can be a criticism, or for example, when the feedback is expected. Okay, for example, if we are doing an appraisal after an evaluation, an exam, or if not expected, for example, after a night shift, or after after consultation, or after a critical incident, for example. This is quite important, the way how the feedback is done, the language employed to transmit, the message to us. But the most important thing is that it's not easy to receive feedbacks, okay? Because I share with Efe an experience in which we have 2 cases, one expected and one non-expected feedback. In each case, we didn't receive well the message, and it's not.
And why was the feedback not done well? I don't want to know what the case was, but what was it about the feedback that wasn't done well?
I think that one of them wasn't a feedback, was a criticism. And after a shift, for example, another colleague who just want to show how much I know more than you, and it wasn't a feedback.
So it felt like a criticism rather than a feedback of how you.
Sometimes it's easy to feel like this, but the other way, in the opposite, was from a colleague, a supervisor, from an educational supervisor, who was right, and with being right, he was right. I didn't take well the feedback, but after all, I think that the most important thing is that we both we reflected on the message, okay, and we learned, okay, we analyze, we reflect, and the most important thing after the feedback is, I think, is share the behavior,
Yeah, no, I think that's really, and I think who the feedback comes from, which is what you're highlighting there as well, is very important. Your educational supervisor, you've got a prior relationship with, you may or may not respected him, you may have had lots of positives from him in the past, and I think that's really important, of who the feedback comes from as well as what's said. So I think that's a point well made. Okay, let's hear from group 3. I know you don't know which numbers you're in. Another group that we haven't heard from.
So I think I was technically in breakout room 3. So all of the above really was said and mentioned. We had slightly larger groups. We mainly just got through to sharing some feedback experiences, not analysing it. I think, like one of the other groups said before, time is important, but also Maya had an experience where it was fed back to the wrong person. She was getting criticism of someone else, and the feedback was coming back. she still learned from it, which is important. The fact that can be learned and from, but obviously I don't know. We didn't, as I say, we didn't analyze, but whether she felt that she respected that person less, or was less intentional to take on board that feedback because it was delivered to the wrong person. So if it's overriding, and I think I was going to go on to talk about how with the community hospital kind of thing we're doing, is there has been some significant events, and as I was raising these kind of, we need to do feedback, they were very defensive of, do not criticize minor staff from multidisciplinary. So it's also multidisciplinary how we communicate with, yes, well, I think we're used to having feedback as doctors, but other multidisciplines won't have the kind of process that we go through, and what the learning is out of it, and more of the learning rather than the criticism of someone.
Yeah, that's a really good point for multidisciplinary, because as doctors, even from teaching the medical students this, so actually you've been brought up on this. But as you say, especially if you have cross professionals, a doctor criticising a nurse and vice versa, that may be perceived as much more less effective. And in a team, that we do have to work out how we're going to do it, isn't it? Because like in the community hospital, you're going to be working with that team for some time. In the practices, you may not like feedback from one of the doctors together to work out how we're going to do this well for each other, because it does actually enhance all our learning. Okay, let's hear from the fourth group then. Definitely silence. That was the group that I was sitting in with, but I didn't speak, and I didn't.
So I think it was similar really to what, I was in that group. It was myself, Preet, and Amanda and Gaurav. So yeah, very similar things to what everybody else has said so far. We talked a bit about kind of how feedback can be, how it's delivered as well, the impact that can have. Preet had said that it's almost like breaking bad news, where the approach of the person, particularly if it's feedback that can be taken in a negative way, or can be thought of as being a criticism, how to sort of frame that, and for it to not be in a public forum and things like that, and for things to be delivered gently. So the importance of that, but also the importance of getting the kind of compliments from positive feedback from patients, and even if it's just a small comment at the end of a consultation, or so that have the kind of boost that can have, especially if we've had a difficult day, a long day, and how much of a lift that can give. So on like we've said before, that feedback it's not necessarily negative, but also positive feedback, the importance of that.
Yeah, and I think that's a really important point when you're in your surgeries with other people. I mean, actually just even thanking the reception staff, who's had a really tough day, or just noticing that the nurses list have been running really late, all that kind of feedback of actually just saying, thank you, or well done for doing this, things like that just do go a long way. I noticed that that patient must have been really difficult. I noticed that you were struggling. It sounds like you did a good job. I mean, people just like even just very simple things like that. Okay, so let's all pull that together. I've done a few slides of what I think is effective and barriers. So if we can go on to the next slide, Ruth, that'd be great. So we've talked a little bit about the prior relationship. Harry talked about it, balance. If you're constantly being told you need to do this differently, you need to do this differently, it's really demoralizing. I think this planned and not impulsive is really important. If you're giving feedback, you don't really want to see that person in the corridor go, oh, by the way, can I just have a quick chat about da 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 da. It's actually trying to plan, as we're talking about breaking bad news, when you're going to do it. And I just remember, just a really small incident, my senior partner just sending me a message one day saying, oh, will you come and see me at the end of surgery? I'd only been in practice about 6 months. So I spent the whole of the surgery absolutely petrified of what he was going to say. I obviously didn't concentrate for 2.5 hours, and I was just thinking, oh my god, what have I done, what have I done? Got to his room at 11 o'clock and went, oh, can you swap a Saturday for me? And it's things like that, it's the timing. If he just said, oh, can I speak to you later about swapping, it's all those sort of things. It's just setting people up. Get to the point. Someone in the group I heard said, sometimes people are far too nice, and they'd actually go round and round the bushes, and actually something's coming, but you don't actually know what it is. And we're going to talk about a couple of models in a minute. Don't give too much at a time, and focus on the behavior. I'm going to give you some examples in a minute, but not something that they can change. And whenever you're going to give feedback, use the I. Don't say, oh, everyone thinks this, or we think this, or anything else. Actually own that feedback, and actually, even though you may have collated it from other people, say, I have noticed this. Next slide, please. So some of the barriers, some of them obviously the opposite from the other slide, but actually when you're in a surgery, or if you're working with a medical student or another colleague, sometimes you don't actually want, you forget really think that you're going to upset it. You're going to work this patient, this learner for another 6 months. Oh my goodness, am I going to damage the relationship? So you need to work on that. And sometimes you're so worried that actually the person you're giving feedback is so lacking in confidence that actually anything you say. So that's why it's a bit about doing this balance. If you do a lot of good, positive feedback, then you can actually come up with some of these other tools we'll talk about in a minute. Mixed messages from different sources we'll come back to. And we're going to have a look at just sort of how we receive feedback, because it's actually really difficult. If the learner is not prepared to change, as we'll see, then actually, that's a real barrier. But sometimes if you just sort of say, oh, your time management is really rubbish, without actually giving them any guidance of how they can change or exploring the options, that's a barrier. And if they don't respect who you are either. And then obviously the ones you've talked about. So next slide about receiving feedback. So most of us, as we all know, absolutely dread it. We don't like, when that patient satisfaction questionnaire is coming in, say, oh, what's going to happen? What are the patients going to say about me? What's going to happen? And I'm sure you're the same when you did your ESRs, when you were registrars, is what's going to happen. And part of it is because you've got this dichotomy. We actually do want to learn and grow, but actually the conflict is we actually want to be respected and accepted. And it's trying to get that balance between those two things in our own minds. And this is a very good book, which actually is saying thank you for the feedback. So if anyone wants to read anything more about it, that's a very useful analysis of what happens. And then let's do the next slide and actually just have a think about what happens when we have feedback and what our brain says. We don't like the feedback we're seeing. What do we do? So sometimes we go, well, that's absolutely can't possibly be right. That's what you trigger. That's your immediate reaction. So it's actually then spending a bit of time to unravel that. Sometimes we don't, it's the relationship that we talked about. If we don't think they're trustworthy, if we think, oh, well, they're telling me off because, like maybe that colleague that you're talking about, what is their background? Is it just to show that they want to be cleverer than you? And sometimes we're just so sort of not sure about ourselves, so we switch off and actually don't listen to it at all. So next slide, please. And then there's these two feedbacks that we can have. And Carol Dwight did whole lot of research in higher education. And basically, she showed that there were two bits. About a quarter of us believe that our abilities are completely unchangeable. So we're completely fixed. We don't actually believe that we can change them. But actually, the other 3/4 of people actually do believe that you can change your abilities. So actually, if you're giving feedback to somebody and you're not actually getting anywhere, it might be just having a think about what their actual mindset is before you go any further. So actually maybe delve in that a little bit more. So when you are receiving feedback, let's go into the next slide. These are just some ideas. Oh, sorry, you're going to have to go through all of them. Sorry, I've not done them individually. You can put them all on, that's fine. So actually don't interrupt the person. Yeah, don't interrupt them. Just give them the chance to say what they've got to say and just take your time to listen. And actually go in with a positive mindset. Don't think, oh my God, this is going to be useless. I'm not going to listen to this. And actually just initially just have a think. Just try and monitor what's going on. What's your initial reaction? Is it, oh, I don't believe this? Or is it, hang on a minute, this is something I need to listen to? But at the same time, I don't want you to be passive. I don't want you to sit and take all this stuff that's coming at you without actually challenging it, because it's their perception. And actually, you may find that actually they have got a perception that may not exactly be what you think happened as well. So discuss what has happened, in a adult to adult relationship, And then there's one more on that side, I think, that's just talking about asking for clarification. If you don't understand it, if you just ask for a bit more information, ask where they, where they're coming from. And one more slide, please. Okay, you can put all these down. But if someone says something nice, like even if someone is said to, oh, I really like, your new hairstyle, or oh, oh, well, I got this down cheaply down the shop down the road, or someone says, you look really nice in that dress or trousers or whatever, don't just, accept it. Thank you. Thank the person for the feedback. Don't explain it, just, take it nicely. But also, after you've had your initial reaction, just take time to actually think about it, reflect on it, and actually decide, because it will be very, very different what you think about it in a little while's time. And if you're unsure, ask from different places, because actually different people give you different ideas, and that's what the multi-source feedback for registrars and us as GPs are. And then obviously the big thing about it is if there is any feedback and you do think that you do need to change, think about how you're going to do it. Think about, make it into a smart PDP, and actually not even if you don't write it down, just think about it like that. So if we can stop that slideshow now, and I'll try and share my screen with the GMC forms on. You can keep it going for now, the recording. So I don't know if you've actually, any of you have seen the, right, let me just try if this is going to work. You see my screen now with the GMC thing on?
Yeah.
Yeah, okay. So basically, this is what the GMC form looks like, okay? It's a lot of, so let me just make it bigger. So a lot of thing about you and who you are, and then why you've come to see the doctor. And then the patient is being asked to rate you in all these different areas. Okay, so 4 up to very good. You're also in the Clarity Toolkit, I can't remember what the 40th is, you're actually asked to rate yourself as well. Okay, so these are what the patients are being asked to do. And you're going to ask you how many of these forms you need to fill in every 5 years. And I even had to look it up because even after all these, I still can't remember. You're being asked to, you'll be told to give it to 45 consecutive patients, which is actually quite a lot if you think about it. That's, up to 3 surgeries. It's more difficult online, telephone consultations, but you can send them the link to do these forms. However, as you would expect, a lot of patients don't do it. So it's looking at about 45 consecutive patients, and actually the GMC say, and each of the different cortex are slightly different, they say you need 34 to go above the bench, roughly. Okay, and we'll come to the, yeah, so that's what, so they go through all this, and then there's some the questions here at the end is the doctor is honest and trustworthy. It's interesting, this bit, sometimes the patient get it completely the wrong way around, and you can just tell from the forms. And then are you happy to see the doctor again and confident? And then it asks you all about who you are. Okay, so that's that one. The college questionnaire, the colleague one is very similar. This one, the GMC ask you to give out 20 of these forms, but you need 10 from clinical people, doctors and nurses, and 10 from non-clinical. And again, there's about 15 minimum, they say. So you fill in these forms, and actually you also score yourself about where you are. So if you think you're satisfactory, you will tick this on the toolkits, and then the toolkits all collate these. Clarity charge for these to be done. I don't know what 14 Fish do for you, but Clarity charge, I think last time I did it was about £40. And they get you all the forms to send out. Last time I did it was paper, and then they collated it. And then once they get enough, then they actually put it on your toolkit for you. So you go through all this, which is all absolutely hunky-dory. And then are they, all about ill health and all their professionalism as well, who you are. But this number 20, there's also one of the patient one as well, is any other comments. And that's often the most interesting bit about the other comments. So that's quite interesting as well. And then again, who you are and how often do you work with these people. So some of you will actually work in very small practices and you may struggle to get this number of colleague surveys. So just think laterally, think people that you may have worked with, people you've worked with on out of hours, you know, your district nurse, if you have any contacts with them, so pharmacists. So just think why. Okay? So things that you thought, oh, it's really nice to think that, you know, I'm caring or I explain things clearly or whatever. Then the next thing to do is actually things that you were surprised to see. And when you go back to the pleased to see, actually, are you making the most of your strengths? Actually just thinking, actually, they may sound really, really, really good at teaching, but actually, I don't teach at all. You know, I've only taught the nurses on one tutorial over the whole year. So it might actually highlight areas that you can develop in areas from your feedback from either the patients or the staff. So then, you know, any areas that you thought you're surprised to see, things that you expected to see, like, you know, that one I've just talked about, time management. The last appraisee I did who had dreadful time management, and she was near retiring, and she absolutely had no intention what to change whatsoever. She, you know, she felt that she was like that for the last 30 years, whatever. You know, she gave time to the patients, even though it wound up the staff and the other patients and her colleagues. You know, she wasn't going to change. So actually, sometimes you can't move people forward, and you know, you need to, you know, help them point out, you know, who they're affecting. And then obviously you get your developmental priorities from the feedback. So I want one of you to be brave enough to volunteer to get the feedback from this colleague survey. Who's brave enough to take this feedback? It's not obviously on you, but you can, you know, how it would feel. Who's brave enough to do it? It's not that bad. You've all gone quiet.
Yeah, I can try.
All right then. Next slide then. Well done. So this is, it's coming. Hold on, wait for it. Right, so when it comes, we'll have Gordon and Sanya. I can see you there looking. If you can help go through this with him and see what sort of things you would discuss with him. Okay, we'll just give him time to read it. And then try and give him a balanced view. This is what his colleagues have said about him. Okay.
Oh, okay.
Are you happy to do that, Sonia? So you're actually, Gora's going to say how he might react, and you're going to be helping him look at it in a more objective way.
Okay. So shall I just read it, the first one?
Yeah, well, I say, or as I say, when you go, Gora, do you want to speak about how you're feeling if you saw that written about you?
Okay. Sometimes it is difficult for the nursing team to approach Dr. X.
I mean, I would immediately sort of feel like I need to find ways to improve that, honestly. So yeah, because I feel that I am sort of approachable, but if the nurses feel that they can't sort of reach me for whatever reason, then I'd like to sort of address that.
Okay. Dr. X is a great GP and a supporting partner.
That will make me feel very happy.
That's nice. Dr. X is very popular with the patients and their families.
Again, very happy.
Okay. Dr. X is usually grumpy when on call, which is a shame as it is okay rest of the time.
Again, I think then that could need some reflection.
I think everybody's grumpy when they're on call.
I mean, what I would, it is, that it's just examples, and people, these are real things. This is what people do right, because obviously it's completely anonymous. So what I would do is, if I was with you, sorry, go on.
I would say it's not completely wrong.
I mean, what I would do is actually try and look at the positives, obviously. You know, his partners think he's great, the doctors think he's great, you know, everything's great. So what is it about this nursing team and this on-call? And I would try to unravel that, because you may find it's the same issue. You may find that every time the nurses knock on your door, you know, you actually react. So you may be able to look at ways of actually, I know duty days, as I say, none of us are at the best of our duties, but actually it's looking at how we can actually help. You know, for example, instead of all the nurses knocking on the door, one after each other, you know, could they send you a message first or something? You know, it's just different ways to look at it, because 1 and 4 are possibly exactly the same problem to the rest of the team. You know, because the nurses team probably do approach Dr. X mostly when he's on call. So it's actually just trying to take it back, and as you say, you have your initial reaction of, oh my goodness, but you see, it's very defensive to, you know, say to that, well, we're all grumpy on call. What does everyone expect? You know, the GP's job is really, really difficult. You know, what do people expect? But actually, that's your initial reaction. But actually, then taking a bit of time just to, you know, reflect on it and actually decide, you know, maybe get more information from other people and do it from that. So that's just an example. Okay, so what I was going to do is just briefly look at some of the giving of feedback now. So that's all about receiving. Is everyone happy about how to receive feedback? You know, not only for the appraisal, but also for the ad hoc informal feedback as well.
Yeah.
Yeah, okay. So is anyone in any roles they're doing at the moment giving feedback to somebody regularly? Doctor or nurses or anybody else that you might be mentoring?
Yes.
Yeah, debriefing.
Okay, who have we heard from? Sania or Harpreet?
Yes. Well, I'm giving feedback regularly to the registrars that I'm debriefing, students during the teaching. If we are doing, for example, something like play roles, then nurses and HCAs during the supervising clinic, which is clinic along with doctor on call, because my practice is big practice. So there is quite a lot of feedback. And now I'm really curious to see my colleagues' survey feedback.
Okay, so I'm going to give you some examples to say. Anyone else? So, Harpreet, let's go to you. You're giving feedback. Have you ever had any training or feedback or how you should do it? Or
yes.
Let's hear from Harpreet, and then we can hear from anybody else who wants to chip in after that. So you're not all got your videos on, so I can't pick on you all.
I don't know if I've been given sort of formal teaching on how to give feedback, but informally I sort of help teach medical students in the practice, and the lead clinical tutor, we've sort of gone through in an informal basis of how to give feedback. I think a lot of it's sort of based around sort of the things that you've talked about today, really about sort of, you know, how to give them positive sort of feedback, which is quite constructive as well. So not to sort of say, oh, this wasn't good or that wasn't good, but actually what the things they did well, how to help them to build their confidence and that sort of thing, really. And especially sort of when to give feedback. So, you know, sort of again, sort of judging things by the day as well. You know, if things have gone really well, then it's a good point to give feedback. If things haven't gone well that day, then, you know, could that feedback be left for, you know, the next session or something like that, and that sort of thing.
Lovely. Okay, well, we'll look at a few bits of theory now, because I think it is important. A lot of what we've already talked about is based on something. So I have the next slide, please. So these are just the principles of feedback. We're not going to spend a lot of time doing this, but just so you know, it is based in, next one, sorry. So the principles of feedback from Brown and Lee, really it's being descriptive. Describe what you're seeing. You know, and we'll come to examples in a minute. You know, you just want to say, I observed this, and then actually allow it to actually be then discussed. Very, very specific. Do not, actually, if we go to the next slide, sorry. Sorry, that's it, yeah, that's right. So for when you're talking about descriptive, is, you know, saying you were really rude. You know, that's actually your, that's your interpretation of it. But actually, if you can say, actually, you know, and if you're watching video, you can say at 11 minutes and at 14 minutes, you cut off the patient mid-sentence. And then that's very descriptive. In videos, you can always go back and play it again, of course, and look at other ways of doing it. So actually, I don't like your attitude, again, is a very objective, but actually, you know, saying that what they actually did, you know, in a terminal situation is actually much more productive. I like that last one. I'm sure some of us on them from various places, especially when we're junior doctors, had that. So if we can go back to the slide before, please, sorry. Right, so descriptive we've talked about, very, very specific, directed at the behaviours that can be changed. We've talked a lot about being timely. Sometimes when you watch or see a student or somebody consulting, there is just so much going on that you just think needs improving. So actually, sometimes it's actually focusing on 2 or 3 main things. And either you choose, if there's mega patient safety issues, that you might have to choose, but often you can ask the person who you're observing what they would like to focus on. Okay, so just don't try and do it, because that will actually completely demoralize them if you actually go for the whole thing. And you're actually giving suggestions, you know, have you thought about doing like this? You know, what other ways could you do it? And in the Cambridge Calgary and feedback mechanism that we're going in through in a minute, there's a lot of suggestions. And the other word I really like is offers. This is an offer of how you could do it differently. Okay, if we can go right down then, please. We'll skip through a few slides because we've done all that, and we'll go to the generic feedback models. Yep, keep going. Lovely, lovely. Right, so these are 3 feedback models that you may well have heard of. Anyone gonna say what Pendleton had to say? Who's heard of Pendleton? I don't believe you. No, nobody's heard of Pendleton's feedback. You will know when you hear from it. Basically, Pendleton.
The positives first and the negatives. Is it that one?
That's correct. Yep. Pendleton actually worked with 3 other doctors, educators in Oxford, and the other 3 educators always get completely forgotten because Pendleton was the first one on the list. So he first did his model of consultations back in '84. And so basically, he wrote his rules for feedback in 2013. And yes, you're exactly right. Just go to the next slide. You actually agree when you're going to give the feedback. You clarify the matters, and then you ask the learner what they did well, what they thought they did well. And then as the educator, you say what you thought he did well. He says what they think they might do better, and then what changes can I recommend. Has anyone been fed back to like this before, and what problems did they find? You must have been when you were practicing for your CSAs and things. I can't believe that you didn't have Pendleton for a while.
Especially for the video feedbacks, you know, when we did video consultation feedbacks.
And how did you feel about this model? Anyone got any thoughts about you like it or don't like it?
I think one of the things I always found uncomfortable is, what do you think you did well? I always found it quite uncomfortable because I'm like, you're supposed to be telling me that. So yeah.
I think that's the thing. It is. If you're not used to it, thank you for that. It's very difficult to actually say what you did well. But actually, if people give a bit of a guidance, is, you know, how did you make that patient feel at ease or something like that? Then sometimes actually giving a bit more guidance about how you did things, because you did make that patient, you know, look at ease. How did you do it? That can often help. Any other thoughts about Pendleton from anywhere?
Well, just on the point of what I thought, it's always difficult to come up with it, but it kind of, even though it's kind of a throwaway comment, I find they don't really care about what you thought you did well, but it opens you up for saying what you could improve on and what you thought did well. So it kind of opens up the learner into actually, okay, this is doing well, but then they're already thinking about, okay, he's going to ask me why I did badly now, and or what am I going to improve? And it kind of opens up the thought of that.
I don't know who, sorry, is it Nikia Carter? I can't yep. Thank you for turning your video on. Tell me what you think.
I think, while regarding talking about what I did well, at that moment, I wasn't thinking about what I did well. when you're giving me the feedback. I want to know what I need to improve. So even if you're telling me what I did well, I may not be listening to it. I'm waiting for what I could have done better.
Exactly. And that's what everyone says. And also it's so time consuming as well. So that was the other thing about it. I mean, I'm going to swear here, but I'm not used to it. But there's a saying that everything before but is bullshit. You know, so actually, yes, you did this fantastically. I really, really like this way. And as you rightly say, you're just waiting for the but. So that's the disadvantage of it. It's very, very good when you've got new learners and actually you're trying to get them used to the feedback. But once you've got, if you become GP trainers, you'll actually find that most of the registrars don't want to listen to it anymore. You know, they would much rather hear about, you know, which is a shame, but it goes back to us all waiting for the criticism, isn't it? So it is really powerful. And also, if they do something naturally, it's quite nice to be able to point out that they do things well so they can do it again. You know, you really listen to that patient actively really well. You know, the way you nodded your head, the way you used your hands or something. It is useful to be able to do it. Right, there's two more ways of models of feedback. The next one, can we have that next one, please? I hope you've all had supper. Feedback sandwich. This is what we were talking about earlier about, you know, it balanced. And I don't think you should do it quite like this. I don't need to say, yes, this is good, this isn't, this isn't. I think it's balanced over a period of time. But that's one model. So you actually, you know, sandwich it in between. So you actually leave the chat with them with something positive. So that's the third one. And sorry, that's the second one. And the third one comes, next slide please, comes from Cambridge, Calgary. Did any of you learn Cambridge, Calgary at medical school? Because they're doing it, they're teaching it now in a lot of medical schools. It's the preferred model for consultations at medical schools now. So it all depends how old you all are. And this was based, Cambridge, Calgary is between Calgary in Canada and obviously Cambridge here. And if we go to 2 slides on, so it's a feedback system called Aloba. Have any of you heard of Aloba? Yeah, some of you, a few nods. And basically, it's what the learner actually says what they want to get out of it. So it may be something like, actually, I've really, really struggled to share the management plan with my patient. Help me with that. So they sort of said, I want help. That's my agenda. Okay, so you let the learner lead it, and actually you look at what outcomes you want. Okay, and then you look at options. Okay, so we'll just head to the next slide, please. So the student identifies, looks for outcome, and then self-assessment, as we had in Pembrokeshire as well, and then you describe this feedback on the next slide, please, which is called Set Go. This is really, really useful when you're actually trying to debrief somebody about what they've seen. So what did you see what did they see as the person doing the consultation? What else did you see? Think about it, set your goals, and how are we going to get there? And this is the word offers. Okay, so the word offers of how we're going to get there. So next slide, please. I'm not going to go and say, if you want to look it up, obviously you can do more. And if you all, when you become GP trainers, should I say, which I hope you all do at some stage, you'll learn a lot more about this. So the advantage of Aloba is it's a much more balanced, it's self-assessment, but again, you need a level of learner to be able to look at themselves, offer suggestions, and then you can go back and rehearse them. You can actually say, okay, then, well, if you did this, how would it look? You know, and then do alternatives. It's done in a very supportive environment. And at the end, the person giving the feedback summarizes and actually, and you agree on some action points and some learning points. So I've no idea what time you guys are meant to finish, but I thought I've got a couple of scenarios for you just to end with to practice. So before we see the scenarios, let's have a volunteer to give and receive the feedback. Anyone who hasn't spoken, who would like to give or receive feedback, or anyone who hasn't. Nika, she's back. Yeah, are you going to give feedback, Nika, or give it or receive it? You're going to receive it. Carol, someone be brave enough to give us some feedback. And I'm going to be very kind and I'm going to give you the choice of feedback. There's 5 scenarios here and you can choose which one you're going to give to Nikita. Sorry if I didn't say that right.
Neka.
Nika, sorry. Come on, who's going to be brave? You've all turned, lot of you turned your cameras off so I can't see you.
I'll volunteer if no one else does.
Oh, Becca, that's too good of you. Anyone want to take Becca? Becca? Okay, Becca. You can either, actually, Becca, it's up to you whether you do it well or badly then giving us feedback.
Oh.
You can choose which way you're going to give it, and then we'll see what the others think of it, okay?
Can I give it badly?
You can give it badly, right. Give it badly, it's much more fun. And it means that you don't have to, right, so let's go to the next slide and let's give, who have we heard from? Julie, which feedback would you like Becca to give?
Wow.
Sorry, I didn't hear that. Which one do you want?
I'm just reading through it, sorry.
Oh, sorry. Or Becca can choose, I don't mind.
Becca, you can choose anyone. That's fine.
Okay.
When I do this at new trainers, I make them do them all. And of course, the third one is the most hysterical. But it won't be me.
I'll pick number 2, if that's okay.
Right, so Becca's going to demonstrate how it can be done. And then I want the rest of you to give feedback to Becca about how she might have done it differently. There you are. And then we'll finish with that.
Okay, shall I just crack on? Yeah. So when are you going to start pulling your weight? It's really not fair. You know, I was really late the other day and everybody thinks it. You know, did you get away with this in your other jobs? I mean, when are we going to, you know, have you finished everything today? When are you going to pay back all this time that we're having to cover for you? Harsh.
Okay.
Receive the feedback. Think about what we said. Receive it.
Thank you for letting me know what's been going on, and I'm sorry that it looks like it's been affecting you or maybe other people as well. It's just, I'm not normally this way, just something's going on recently. That's the reason. And I would look into it. I'm trying to sort it out already. But probably if I can get some support, it would help.
Do I carry on being mean or can we stop it there?
You don't have to. As I say, it was just really an example. As I say, I think it's late and I think you've all had a long day. So if Becca's had, you're happy for us to finish. Let's just have a summary. Let's go back to a recap of the evening. So the final slide. Really, we've looked at, your experiences in small groups. I know 10 minutes wasn't long, and I know it's much nicer to do it and take a bit of time over it face to face, but we are where we are. I really wanted to focus a lot on receiving feedback, because when we teach feedback, we almost always talk about giving it. But actually, in the next couple of years of your life, you're much more likely to be receiving it as well. I know you've not done a lot on appraisals yet, but I just wanted to highlight that. Look at a few of the principles, and because it's educational, we do need to look at the models of the feedback and where the principles come from. And we could have spent longer doing the feedback, but as I say, it's nearly 9 o'clock. So that's me done. So we can finish the slideshow. Thank you. And take any questions or comments or anything anybody wants to say.
Does anyone have any comments or observations or anything for Fiona? No.
Thank you. Just a very useful session. It's been nice to reflect on feedback in detail and various aspects of it. Thanks, Fiona.
Yeah, thank you, Fiona. It's really good to understand taking on feedback, whether positive or negative, and how to receive it. I think that's something that we've got, especially positive ones.
Yeah, I think it is. It's always very difficult because you're often asked for feedback from various educational sessions, and hopefully it might actually make you think about, you know, when we all write things like death by PowerPoint, you know, on some really ones that we found really boring. It's actually trying to give these to people, you know, what you'd like more of as well. So I know that some of our PLT sessions or anything else, you know, or, you know, so it's just actually thinking about those sessions and giving feedback as well, because it is really useful one way or t'other.
Yeah, thank you for that. I thought it was really interesting, and the thing that I really liked as well was I think the offers is a really nice, easy thing to remember. So obviously there's all the models and things like that, but I think something that will just stick in my mind is giving that offer of how, you know, of offering the feedback and rather than, you know, the set models. It just that that offer bit is really helpful. So thank you very much.
It's certainly something I've changed that offers since I understood Cambridge Powerpoint, since I was teaching the medical students. I never used to do that as a GP trainer, but actually it's just, well, you can offer it. If you don't like what I'm saying, you know, then actually it's take it or leave it. And that's a bit about the present, you know, if you don't like it, then actually you can go and recycle it and give it to someone else, can't you, really? But...
Indeed. Excellent. Well, thank you so much for your time. And just to remind you, the fellows, that these sessions are happening monthly, and I should remember what the next one is. I think it is about the drugs don't work, about deprescribing and looking at medication and polypharmacy, by James Lafanu, I think. But we'll be sending invites anyway, but that's next month. And there should be these talks will be happening every month as well. So thank you very much, and thank you very much, Dr. Moore.
We're just saying goodbye.
Been really helpful.
Thank you.
Thank you.